Okay. Thank you to Clinical College Department of Ain Shams for conference. Now we will introduce my dear colleague and professor, Dr. Mohammed Yassin, professor of clinical university. He will talk about frontline ovarian cancer turned up the heat on the PARP inhibitor. Please, Dr. Mohammed.
Thank you, Professor Abdul Muttalib. Thank you. Good evening, my dear colleagues. First of all, I would like to thank AstraZeneca for inviting me in this symposium. These are my disclosures. Ovarian cancer, turning up the heat on PARP inhibitors. As we see here, FDA-approved drugs for ovarian cancer. The landscape has changed in the past 10 years with approval of many new drugs, olaparib, niraparib, rucaparib, and chemo plus Beva for platinum sensitive, and chemo plus Beva for platinum resistant, and pembrolizumab for MSI and deficient mismatch repair genes. Recurrent ovarian cancer platinum combination. As we see here, different combinations combining platinum with different agents. The best median progression-free survival was for carboplatin paclitaxel, which was 12 months. And in the recurrent setting, when we added Beva, the best response was 13.3 after adding Beva to carboplatin and pegylated liposomal doxorubicin. So, as we see here, the gap is getting shorter between the first relapse and subsequent therapy. So the gaps between successive lines of treatment becomes shorter, and we have to search for something new to increase the gap between successive lines. So understanding DNA repair as a target for precision cancer therapy. As we see here, this is very important. DNA damage response pathway drug targets. Our first is single strand break, and the repair target is PARP. And the repair pathway is base excision repair. And the damaging agent, chemotherapy, is alkylating agents. And rationale for targeting is the most common lesion. Then we have double strand break with two pathways or repair targets, ATR, homologous recombination repair, and the chemotherapy damaging agent is topoisomerase inhibitor. And we have also ATM DNA, non-homologous end joining, and the chemotherapy damaging agent is topoisomerase 2 inhibitors. And the rationale for targeting it is the most cytotoxic lesion. Then we have bulky adducts, example from platinum and ultraviolet rays, ER-CC1, XP proteins polymerases, nucleotide excision repair and translesion senses, and the damaging agent is ultraviolet light and platinum agents. Rationale for targeting is platinum potentiation, but safety concern over UV sensitization. Then we have nucleotide mutation, substitution, deletion, and insertion. MLH, MSH, mismatch repair. Replicating errors, and the damaging agent is alkylating agents. And rationale for targeting is increased mutational load. As we see here, PARP and homologous recombination. PARP, first, there is single strand break. And this single strand break is corrected by PARP enzyme. And if we inhibit the single strand break through PARP inhibitor, our cell can exhibit double strand break. And double strand break can be repaired through homologous repair, recombinant repair, and DNA and DSP is repaired, and this will lead to normal cell growth. But if we have a homologous repair deficient, so DNA and double strand break persist, and this will lead to cell death. So mutation in BRCA1 and BRCA2, RAD51, Fanconi anemia gene, PALP2, and other genes that encodes protein necessary for normal repair lead to homologous repair deficiency and inability to repair double strand break. So high-grade serous ovarian cancer, potential benefit of PARP inhibitors in 50% of the patient. So HRD is not only BRCA, germline, or somatic mutation. Other mutations exist which lead to homologous repair deficiency, which is a target for PARP inhibitors. Are PARP inhibitors active beyond BRCA mutation? As we have learned from several trials, that for example, in the olaparib study 19, the hazard ratio was 0.54, and for niraparib in the NOVA trial, 0.49, and for rucaparib in the ARIEL 3 trial, 0.44 to 0.58 for patients without a germline BRCA mutation who are treated with PARP inhibitors, which means PARP inhibitors also work in patients with wild BRCA mutation. So in patients without BRCA mutation, is there a biomarker for homologous repair deficiency? Yes, functional assays, genomic scar assays, gene signature, homologous recombinant repair gene alteration, which all lead to BRCAness and is a target for PARP inhibitor. HRD test based on genomic instability, Foundation Medicine HRD test for rucaparib, loss of heterozygosity, LOH score, Myriad My Choice HRD test, LOH score, TAI score, allelic imbalance extending to telomerase, LST score, large-scale transition breakpoints in adjacent regions of 10 megabase. This will lead to the combined HRD score, and the score over or equal to 42 is equal to HRD positive. So BRCA testing guidelines, who all patients with invasive epithelial ovarian cancer, excluding borderline and mucinous, including fallopian tube and peritoneal cancer, independent of age or family history, when a diagnosis or if not undertaking a diagnosis at any stage during the patient pathway. How? Germline testing of a blood saliva sample in the first instance, testing of tumor tissue if a negative result is obtained to identify those suitable for PARP inhibitor therapy who are not germline carriers of a BRCA mutation. So here are phase 1 and 2 trials of olaparib for patients with BRCA mutated tumor. And as we see here from phase 1 and phase 2 trials, there was 28% complete response or partial response in phase 1 trial and 33 in the phase 2 trial. And the median duration of response was 7 months and 9.5 months in the phase 2 study. Also, olaparib is active in BRCA mutated and non-BRCA mutated patients with ovarian cancer, as we have seen, as we are seeing here in the waterfall plot. So, concept of maintenance trial, randomized phase trial to assess novel agents. As we see here, the interval between end of relapse therapy and the restart chemotherapy for clinical progression. We can increase this gap through adding biological agent, then restarting chemotherapy. But we have to look for useful difference in progression-free survival. Randomized trial of maintenance olaparib in platinum-sensitive high-grade serous relapsed ovarian cancer. We have the study 19, in which patients have received more or 2 previous platinum regimen and have achieved partial or complete response. And BRCA1 and BRCA2 mutation was recorded if available, but was not mandatory for the study. And patients have been randomized 1-to-1 to the historical olaparib 400 milligram. As we all know, the tablet dose now is 300 milligram versus placebo twice daily. As we see here, for the whole population, the median progression-free survival was 8.4 versus 4.8. And for the subpopulation with BRCA mutation, it was better. It was 11.2 versus 4.3. And progression-free survival in BRCA wild type, excluding germline and somatic BRCA mutation, also there was a benefit. For olaparib, it was 7.4 versus 5.5. So, PARP inhibitors maintenance significantly extend progression-free survival, benefit seen in patients with or without BRCA mutation, magnitude of benefit greatest in patients with a BRCA mutation. All patients with high-grade ovarian cancer responding to platinum-based chemotherapy can benefit from a PARP inhibitor. So, how valuable is the clinical benefit and what are the side effects of PARP inhibitors? Here, long-term survival shows there are patients from the study 19 responding to olaparib for more than 6 years. 11% of patients remained on treatment for more or equal to 6 years. And the most common adverse events, as we all know, the adverse events of olaparib are nausea, fatigue, and vomiting, and anemia. Here is the algorithm for patients with recurrent ovarian cancer. And what is very important here is the treatment depends on tumor biology and histology, number of prior lines of treatment, prior response, treatment-free interval for platinum, persistent toxicity, symptoms, and patient's preference. And if there is surgery, if surgery is an option or not. Then eligibility, platinum might be the best option, and re-challenge seem to be justified on response to prior platinum. Eligibility for platinum or potentially platinum responsive. First, no priority for a symptomatic response or contraindication to BEVA. Platinum-based re-challenge. Offer PARP inhibitor after response to platinum if not contraindicated. But if the priority is for symptomatic response or we have a high burden disease and there is no contraindication for BEVA, we offer platinum-based re-challenge plus BEVA. So, first-line treatment of ovarian cancer. Frontline treatment option for advanced ovarian cancer, the standard of care. First, we have to do genetic risk, germline testing, then surgical cytoreduction, primary debulking surgery, and somatic testing of the specimen, adjuvant therapy, patient-based, platinum-based chemotherapy plus or minus BEVA, and maintenance therapy, either observation or PARP inhibitors or BEVA. So, where are we now? Carboplatin and paclitaxel are the mainstay of treatment. Addition of BEVA to chemotherapy followed by maintenance has extended median progression-free survival by around 4 months, according to the ICON 7 and GOG 218 study. But overall progression-free survival following first-line therapy has changed little in the last 20 years. Progression-free survival is affected by FIGO stage, amount of residual disease, and BRCA status. BRCA mutation confer a better prognosis. And what is the outcome of these patients with standard of care chemotherapy and BEVA? As we see here from the GOG 218, in patient with BRCA2 mutation, the median progression-free survival was 21.6, BRCA1 15.7, and other was 16 months, and no mutation, it was a little bit lower, it was 12.6. Patients with BRCA mutation have a longer progression-free survival than BRCA wild type. Relapse still occurs in most patients of these patients within 3 years of diagnosis. Current chemotherapy with BEVA leads to a high first failure. Can olaparib maintenance therapy following frontline therapy significantly extend progression-free survival, and will this lead to an increase in overall survival? Here comes one of 4 trials in newly diagnosed ovarian cancer. And the most important one, and the first trial, was SOLO-1, in which olaparib maintenance therapy after frontline treatment in women with BRCA-mutated ovarian cancer was added to the treatment after chemotherapy, after surgery, and then chemotherapy. And if the patient is in clinical complete response or partial response, and we have to test for germline or somatic mutation, patients are randomized 2-to-1 to olaparib 300 milligram twice daily versus placebo. And study treatment continued until disease progression, and patients with no evidence of disease at 2 years are stopped treatment. Patients with a partial response at 2 years could continue treatment. Primary endpoint was progression-free survival. Secondary endpoint, progression-free survival versus blinded independent central review. Second, progression-free survival, overall survival, time from randomization to first subsequent therapy, time from randomization to second subsequent therapy, and quality of life. Here, this data was presented in ESMO 2018, and the median progression-free survival for olaparib was not reached at that time, and for placebo it was 13.8 with a hazard ratio of 0.3, which is highly significant. And if we look to the curve, there is a very good separation between the olaparib and the placebo arm, which we sometimes call banana curve, because of the beautiful splitting from the start between olaparib and placebo. And what is very interesting, at 3 years, there was 60.4 progression-free for olaparib and 26.9% progressive-free at 3 years for placebo. These are the progression-free survival subgroup analysis, and all are in favor for olaparib. And safety summary, again, is a little bit higher in olaparib versus placebo, with 28.5% treatment-related adverse events leading to dose reduction, and 11.5 treatment adverse events leading to discontinuation for olaparib arm. Here, the most common treatment adverse events was anemia and neutropenia and fatigue. Here is the update presented a few days ago in the virtual ASMO 2020. And as we see here, the median progression-free survival, it was not reached at 2018, and it was 13.8 for placebo. And here again, it was for placebo 13.8. And the progression-free survival here is 56 months with a hazard ratio of 0.33. Again, in subset endpoints, progression-free survival benefit for second progression-free survival overall, it was not reached for olaparib, and for placebo it was 42.1. For patients in complete response, for olaparib it was not reached, and for the placebo it was 52.9. And time to subsequent therapy for overall, it was not reached in olaparib, and 40.7 for placebo. And patient in complete response at baseline, it was again not reached in olaparib versus 47.7. As regarding safety profile, no additional cases of MDS or AML reported, with the incidence remained below 1.5. Interpretation of adding olaparib maintenance to first-line therapy in patients with a BRCA-mutated ovarian cancer, significant prolongation of progression-free survival. Median progression-free survival was 56 months in olaparib arm compared to 13.8 in placebo. 48% of patients remain progressive-free at 60 months. After 5 years of follow-up, no safety concern and no new MDS and AML reported. Results of SOLO-1 underscore the importance of early checking for a BRCA mutation in all new diagnosed ovarian cancer patients. Here are a comparison between the other trials. We have SOLO-1, advanced ovarian cancer and BRCA mutation, complete or partial response to platinum-based chemotherapy. And here certification is according to BRCA mutation, germline or somatic. In the PRIMA study, it is the same like SOLO-1, but certification is according to HRD positivity. But PAOLA-1 and VILEA study certification is for all comers. This is the design of SOLO-1, which we explained before. Then PRIMA study, patients are randomized prospectively according to HRD testing to niraparib versus placebo. And our famous PAOLA-1 trial, maintenance olaparib plus Biva in newly diagnosed advanced ovarian cancer after platinum-based chemotherapy plus Biva. Patients are randomized to olaparib plus Biva versus placebo plus Biva. Remember here, the comparison or the comparator is not a placebo. It is an active controlled drug, Biva plus placebo. And we have the VILEA trial, in which we have 3 cohorts, vilaparib throughout the treatment, vilaparib plus chemotherapy, and then vilaparib maintenance, versus vilaparib alone and vilaparib and placebo maintenance, versus chemotherapy plus placebo versus placebo maintenance. PAOLA-1 trial, which was presented ESMO 2019, in which upfront or interval platinum taxane-based chemotherapy, and patients had to receive at least 2 to 3 cycles of Biva, and then complete or partial response, and randomization is 2 to 1. Olaparib 300 milligram twice daily for 2 years plus Biva versus placebo for 2 years plus Biva. Primary endpoint was progression-free survival, sensitivity analysis, progression-free survival, blinded review. Secondary endpoints, time to subsequent therapy, second progression-free survival, overall survival, health-related quality of life, and safety and tolerability. Here are the patient characteristics, well balanced between the 2 arms, again. And the progression-free survival in the intention to treat population was 22.1 months for olaparib plus Biva versus 16.6 for placebo plus Biva. Hazard ratio was 0.59, with good separation between olaparib and Biva versus placebo plus Biva. And here are the forest plot of the progression-free survival subgroup analysis, and all are in favor of olaparib plus Biva. Here, it is very important to announce that in the trial, 29% of patients were BRCA mutated, and 19% were HRD positive, excluding BRCA mutation, and the total HRD positivity, which is the target of PARP inhibitor, was 48%. So we have to look for the cause of HRD, BRCA test, and HRG, homologous recombinant repair gene panel test, and look for the effect of HRD, genomic instability, loss of heterozygosity, telomeric allelic imbalance, and large-scale state transition. And we have to analyze the specimen performed on DNA from formalin embedded tumor tissue and assess two factors to determine HRD status: tumor BRCA mutation, yes or no; genomic instability, loss of heterozygosity; telomeric allelic imbalance; and large-scale transition. And score is out of 100, and we have to said before it must be above 42. Testing for homologous recombinant repair mutation alone doesn't identify all cases of ovarian cancer with HRD. We have BRCA mutation, other homologous recombinant repair gene mutation, altered homologous recombinant repair gene expression, and other identified causes, and all account for the HRD and genomic instability. Progression-free survival by BRCA mutation status, it was very high. Median progression-free survival was 37.2 versus 21. Highly significant homologous hazard ratio was 0.31. And if we have HRD positivity including BRCA mutation, it was the highest, 37.2 versus 17.7. And then HRD positivity excluding BRCA mutation, 28.1 versus 16.6, hazard ratio 0.43. And the worst outcome was for HRD negative or unknown with a hazard ratio of 0.92. The most common adverse events, as we all know, hypertension, anemia, lymphopenia, and fatigue. And progression-free survival by risk in tumor BRCA mutation patients. Higher risk tumor BRCA mutation, olaparib plus Biva. Median progression-free survival was 36. Placebo was plus Biva was 19.4. For lower risk, it was not reached for olaparib plus Biva versus placebo plus Biva 22.2. And for clinical risk in HRD positive patients, for higher risk, it was 36 for olaparib Biva. In placebo, it was 16. For lower risk, it was not reached versus placebo plus Biva, it was 22. So, conclusion in Paula 1, maintenance olaparib plus Biva provided a progression-free survival benefit over Biva alone in both the higher risk and lower risk subgroup. The reduction in the risk of disease progression or death was 40% in higher risk patients and 54% in lower risk patients. Median progression-free survival increased from 14.7 months with Biva alone to 20.3 months with the combination of olaparib plus Biva in higher risk patients, and from 22.9 months to 39.3 months in lower risk patients. Consistent with the overall Paula population, olaparib plus Biva provided the greatest progression-free survival benefit over placebo plus Biva in higher and lower risk patients who were HRD positive or who had a tumor BRCA mutation. The substantial progression-free survival improvement seen with olaparib plus Biva in lower risk patients with a tumor BRCA mutation or who were HRD positive with 2-year progression-free survival rates of over 90%, raises the hope of long-term benefit or even expecting cure in such a case of ovarian cancer. The update, which was presented a few days ago in ESMO Virtual 2020, second progression-free survival for olaparib Biva, it was 36.5 versus 32.6 placebo plus Biva. And patients received, and remember, some of the patients, the placebo arm, have received PARP inhibitor in subsequent treatment. Second progression-free survival have a group analysis by HRD status. As we see here for HRD positive, including tumor BRCA mutation, olaparib plus Biva, it was 50.3 months versus 35.3 for placebo plus Biva. For HRD positive, excluding BRCA mutation, olaparib plus Biva, it was 50.3 versus placebo plus Biva, 30.1 months. And HRD negative, it was 26.3 versus 28.1. Interim over analysis, it was not reached for olaparib plus Biva versus placebo plus Biva, it was 45.8. Immature over analysis, overall survival analysis, the low event rate, 38%, means that definitive conclusion cannot be drawn for now. Here are the RECIST objective response rate and best overall response, and the best response for olaparib plus Biva was in the BRCA mutated subpopulation, and then HRD positive including BRCA mutation, and then HRD positive excluding BRCA mutation or BRCA mutated negative, then HRD negative, and the overall number also was in favor as regarding the RECIST objective response rate for olaparib plus Biva versus placebo plus Biva, with high patients with complete response and partial response. Safety analysis was consistent with what we have seen, with some increase in hypertension and anemia. Here is a comparison between the 4 trials in the newly diagnosed first-line ovarian cancer. Key similarities among 4 trials: all received PARP inhibitors in a maintenance phase, strong benefit shown in BRCA mutation and HRD positive population. Key difference: population studied, duration of treatment, active comparator in Paula 1 trial, which was a placebo plus Beva, and statistical analysis between the trials. PARP inhibitors showed benefit in HRD positive population. HRD tests used in trials available in the United States, but not in Europe. No clear benefit of PARP inhibitors in patients who are HRD negative, as we have seen in the Paula 1 trial and Villiers trial, of hazard ratio of between 0.8 to 1. So what is the best way to treat patients without a BRCA mutation or who are HRD negative? PARP inhibitors in newly diagnosed ovarian cancer. What are the options based on data? PARP inhibitor plus Beva, Paula 1, need to make your decision early. Chemotherapy plus PARP inhibitors in Villiers for all comers. PARP inhibitor maintenance only, like in the Prima and Solo 1 trial for HRD positive or BRCA mutated patients. These are the NCCN guidelines, and as we see here, for patients after surgery and receiving chemotherapy and no Beva used during primary therapy, for BRCA wild type, for complete or partial response, we have the option of observation or niraparib. And for patients with germline or somatic BRCA mutation, for patients with complete or partial response, we have the option of olaparib or niraparib or observe. For patients who have received Beva and are BRCA 1 and 2 wild type, complete response or partial response, Beva plus olaparib or Beva alone. For germline or somatic BRCA and BRCA 2 mutation, Beva or olaparib or olaparib alone. Conclusion: PARP inhibitors are a new class of drug targeting DNA repair pathways. Deficiency of HRD homologous recombination repair of DNA is the phenotypic marker of activity. Platinum sensitivity response is the best identifier of activity in recurrent disease. Highest level of activity seen in BRCA mutation carrier. Testing for BRCA mutation is the key in selecting patient for first-line maintenance therapy and identifying an affected family member. And remember, we have to test also for HRD, which is very important. And the good news that very soon we will have an HRD standard test here in Egypt, which denotes that we have to test for HRD and BRCA mutation from the start of ovarian cancer treatment. Targeted therapy with PARP inhibitors in recurrent ovarian cancer maintenance olaparib has shown a clinical significant extension progression-free survival with long-term survival in some patients. In frontline treatment of patients with a BRCA mutation, olaparib has led to a major improvement in the progression-free survival at 5 years. In frontline treatment of patients with HRD, olaparib added to Beva led to improvement in progression-free survival, second progression-free survival, as well as overall response rate with no new safety reports on longer follow-up. Thank you for your attention. And I would like to thank again AstraZeneca for inviting me for this talk. Thank you.
Thank you, AstraZeneca, for this symposium. Thank you, Professor Abdul Muttalib, Mr. Chairman. And I would like to close the session and move to the next session with my dear colleague, Professor Lubna Aziz Al-Arab. It is a Roche symposium with the title, The Evolution of Precision Medicine and the Role of Comprehensive Genomic Profiling.